Good afternoon. My name is Adam Rubenfire, and I'll be moderating today's Modern Healthcare webinar, Reducing Harm by Getting Patients the Right Diagnosis at the Right Time. Diagnostic errors are the most common, catastrophic, and costly of all medical errors and malpractice claims that result in death or permanent disability, with thousands of patients suffering serious harm every year. We're beginning to understand where and when these errors happen most frequently and which cause the most severe harm. It's now on us to take steps to prevent misdiagnoses and ensure patients get the right diagnosis at the right time. We'd like to thank the sponsor of today's webinar, the Society to Improve Diagnosis in Medicine. The Society to Improve Diagnosis in Medicine catalyzes and leads change to improve diagnosis and eliminate harm from diagnostic error. The Society works in partnership with patients, their families, the healthcare community, and every interested stakeholder. It is the only organization focused solely on the problem of diagnostic error and improving the accuracy and timeliness of diagnosis. A couple housekeeping notes before we get started. We want this webinar to be an interactive experience for you, our audience. You're encouraged to ask questions using the questions pane in your GoToWebinar attendee panel. Our speakers will try to address as many of your questions as they have time for. In addition, if you'd like to minimize the attendee panel for a better view of the presentation slides, click the double arrows at the top of the panel. You can also resize the webinar window by grabbing the corner of the screen with your mouse. We also invite you to download a variety of materials from our sponsor by clicking on the handouts pane in your attendee panel. Before we begin, I would like to introduce our speakers for today's presentation. Paul Epner is the CEO and co-founder of the Society to Improve Diagnosis in Medicine. He is chair of the Coalition to Improve Diagnosis, a collaborative of more than 50 leading U.S. healthcare societies, health systems, patient organizations, and quality improvement organizations. He sits on the IHI's National Steering Committee for Patient Safety. Dr. David Newman Toker is a professor of neurology at Johns Hopkins University School of Medicine, director of the Johns Hopkins Armstrong Institute Center for Diagnostic Excellence, and he also leads joint appointments in emergency medicine and health science informatics at the School of Medicine, as well as in epidemiology and health policy and management at the Johns Hopkins Bloomberg School of Public Health. Dr. Newman Toker also serves as the president of SIDM. Dana Siegel is the Director of Patient Safety for CRICO Strategies, a division of the Risk Management Foundation of the Harvard Medical Institutions. She provides analytical and educational services to leading academic medical centers, community hospitals, and physician practices on the issues of medical liability and patient safety. She is a member of the Board of Directors for the Society to Improve Diagnosis in Medicine. And with that, we're ready to begin the presentation. Dr. Newman Toker, the floor is yours.
Thanks very much, Adam. And thank you to all of our audience members for attending today to hear about this critically important topic of major public health importance. If I could have the first slide. The National Academy of Medicine, then Institute of Medicine, issued a landmark report in September of 2015 that highlighted how critical improving diagnosis in healthcare is. And there were three crucial quotes from that book that I'd like to just briefly read to you now, because I think they encapsulate the fundamental essence of the problem. The first is that the delivery of healthcare has proceeded for decades with a blind spot, diagnostic errors. So this is something we haven't been paying attention to. Second is that most people will experience at least one diagnostic error in their lifetime, sometimes with devastating consequences. So this is going to affect all of us. And the third, and really most important, and really an important motivator for why we're here today, improving the diagnostic process is not only possible, but it also represents a moral, professional, and public health imperative. And that's a crucial quote because it's strong language, but it really tells it like it is, which is that we know this is a problem. We can no longer sit idly by and say, this is simply the price of doing business. We know this is a problem that can be fixed, and we have to now develop the moral and political will to make that happen. The next slide, please. It's important as we think about the issue of diagnostic error, and in a moment I'm going to introduce my colleague and collaborator, Dana Siegel, from CRICO Strategies to talk about some of the details of the recent collaborative research together. it's important that we understand what we mean by diagnostic error when we say it. There are some controversies in the field around this, sort of technicalities around definitions, but the definition used by the National Academy of Medicine, and one that I endorse, is as follows: the failure to establish an accurate and timely explanation of the patient's health problem or problems, or the failure to communicate that explanation to the patient. And what's really special and important about that definition is that it is entirely patient-centric. So from the patient's perspective, if I sought some sort of medical attention and I did not find out the correct diagnosis in time for it to make a difference and hear about it, then I suffered a diagnostic error. And I think it's from that perspective, from the perspective of the individual patient experience in medical care, that we should be thinking about the issue of misdiagnosis. Next slide. In terms of overall prevalence and harm, right now we're still building the science of safety around diagnostic errors. We don't have good epidemiologic tracking mechanisms to know exactly how many errors occur or exactly how many patients suffer harm. But all of the evidence points to the fact that this is a major public health problem. A series of studies done in primary care suggests that with extrapolations to the general public, that at least 12 million Americans each year suffer diagnostic error. Based upon that work alone, hospital-based estimates based on autopsy-defined diagnostic errors that contributed to death suggest at least 40 to 80,000 people die just in hospitals alone. Work that we've done has begun to suggest that that number may be low by almost an order of magnitude in terms of the total impact, in terms of deaths and permanent serious disability. And estimates of the costs associated with diagnostic error have started to emerge and suggest that this is a more than $100 billion problem per year. So this is something we should all be paying attention to. And for that reason, I'm really glad that all of you are here with us today to hear about this critically important topic. And with that, I'll turn it over to Dana Siegel.
Thank you, David, and good morning. Thank you, or good afternoon, actually. Thank you, Adam and David, for that excellent stage setting for this important discussion today. What I'd like to do is spend a few moments with you sharing some of the background on the data source and the analytical process of our collaborative study, and the information that led to the key insights that we're going to share with you today, which will be the foundation of the ultimate recommendations that we'll be discussing a little later in this presentation. Next slide, please. So David opened up his conversation by sharing with us that NAM, or IOM as it was at the time, in its publication on diagnosis, noted that most people will experience at least one diagnostic error in their lifetime. This is a look at a 2017 study by the National Opinion Research Center, or NORC, at the University of Chicago, that in collaboration with IHI, MPSF Foundation, Lucian Leap Institute, did a study on Americans' experience with medical error. And of note, 59% of the more than 2,500 participants in this study noted that they had indeed had a medical problem that was misdiagnosed. 42% received a diagnosis that didn't make sense. Next slide, please. This, of course, absolutely validates the work that we've done in the 10-year study that we did in looking at medical malpractice claims, where we validated that the problem is indeed common, costly, and sadly all too often catastrophic. In fact, as you can see from the notes here, among those claims, 34% of serious harms involved a diagnostic error. 34% of serious harms from medical error involved a diagnostic error. 64% of the diagnostic error claims are associated with death or permanent disability, and that is using the NIAC error score or severity outcome score. This is referenced as clinical severity, National Association of Insurance Commissioners score for clinical severity. 64% were high severity. And lastly, diagnostic errors represent 28% of the total payouts of all medical malpractice claims, $2.65 billion in payouts over this 10-year period. So clearly, this is a tremendously common, catastrophic, and costly issue of which we must gain some insights to and begin to understand how we can bring solutions to our clinical communities. Next slide, please. I'm going to take just a moment to share with you where, in fact, this data that we were using as the foundation of the insight development came from. So CRICO is the medical malpractice insurer of the Harvard Medical Institutes, and we've created a national database of malpractice claims. This is a collaborative with more than 20 other MPL insurers across the country who contribute their medical malpractice data to the single collaborative database for studying and benchmarking medical error and patient harm. Some things of note: the value of this database is it involves both captive and commercial insurers, hospitals and physician practice groups. It represents academic and community providers. And in comparison with the NPDB work where claims are reported, it represents nearly 30% of the claims activity in the entire U.S. So we feel it's a very strong representative of the clinical activity where harm and error is being brought to bear through the lens of medical malpractice. These particular cases involved in this study have all been coded by seasoned clinicians who code them under a highly structured and governed taxonomy to capture the individual data points for analysis. The data points that we capture come from the raw data of both the medical record and the legal files. And we get about 8,000 to 10,000 new claims per year. And we have the capacity to look at both open and closed claims and suits. So there was a really rich and robust data set for our analysts and our researchers to use as we began to study this particular problem. Next slide, please. Ultimately, at the end of the coding process, and again, just a little insight behind the curtain, our analysts and researchers have access to a plethora of data points that you can see here on the left side that really come from clinical, legal, and financial data points that are available. You can also see that we provide a detailed clinical summary that the clinicians write so that we can look at the data points and understand where and how they fit together in the story. And our expert coders also provide for us, after assessment of the case, a series of contributing factors that really identify the very specific system and human vulnerabilities that appeared to have led to the harm, the patient harm, and outcomes. With all of this information available to us, next slide, please. What we did specifically for this study was to identify in the CBS database a set of data from 2006 to 2015, so a 10-year set of data, where we identified the diseases accounting for the majority of serious misdiagnosis-related harms. Again, using the NIAC scale for identifying high-severity injury, we looked at those and grouped the diseases according to AHRQ's clinical classification, which allowed us to cluster by ICD diagnostic codes into clinically sensible groupings. Ultimately, the data set that rose to the top that really became highlighted for us to focus on were vascular events, infections, and cancers. And we looked under the hood at each of those, really exploring their frequency, their severity, the clinical setting, and particularly the contributing factors that were driving the issues behind each of these clinical case types. Next slide, please. This slide really summarizes on a very high level what we reference as the big three. And what we're saying here is the clusters of issues in these three categories collectively represent 75% of all the serious harms in this data set. And they are ischemic stroke, bacterial sepsis, and lung cancer as the #1 issue within each of these three categories. So the vascular category, the infection category, and the cancer category. Each had the opportunity for us to look underneath those categories at the top 5 clinical drivers within each category. And again, in our vascular category, we saw ischemic stroke rise to the top. In infections, it was bacterial sepsis. And in cancer, it was lung cancer. But collectively, these 5 subcategories in each of the larger category represent 50% of the serious harm. We call these the top 15. 50% of the disability and 50% of the death. So there is a very profound set of data with very clear diagnostic stories that we can focus on that are really bringing to bear the largest body of harm and dollar value or burden, if you will, to us as clinicians and the human patients and families behind each of these stories. Next slide, please. We have the opportunity to look at the clinical setting before we can even begin understanding how to tie solutions to the issues we identify. We need to understand where those issues are occurring, in what setting, what type of clinical resources are available, and what are the specific issues relevant to each one of these case studies. So as you can see here, we divide this into clinic or your ambulatory physician practice setting, the emergency room setting, and the inpatient setting. And again, it's probably no surprise, given the harm that we see, that in the ambulatory or clinic setting, there is a significant portion of this is accounted under the cancer categories or the oncological diagnoses. And again, no surprise that in ED and inpatient, where we see more acute clinical presentations, that here is where we actually see more of the vascular and infection events. Next slide, please. One of the values of the data that was available to us was really the linkage between the what was happening and where it was happening to the why it was happening, and some of the very real vulnerabilities that we could see in the clinical cases themselves. And again, this coding is done by experienced clinicians who are reading these stories and clustering the vulnerabilities throughout the system and human vulnerabilities that they can capture between reading the medical record and, of course, having the full legal files. So we have access to the interrogatories and the depositions and the expert witness reports in order to assign these contributing factors, these driving sources. And David's going to talk a lot more about the drivers behind these, but on a very high level, we just wanted to share with you that 85% of these cases are impacted by a clinical judgment issue. This is where the cognitive processing, the thinking and planning, the influence of bias on the decisions that we make are represented here. And the result of that process that we are able to identify and capture through the data is issues such as a failure to order or a delay in ordering a particular test that, albeit understanding in hindsight is how we're looking at these, but we're able to see that in real time that test probably had implications that it would have been helpful and it was not done or not done in a timely manner. Quite often that's paired with or matched to failure to establish a clear differential diagnosis, which one can understand how that would then relate to not ordering the right diagnostic test. Other things, as you can see, failure to appreciate relevant signs and symptoms. In this case, from the coder's perspective, that means that these issues were present in a test result that was available, in a sign or symptom that a patient had relayed. It was present in the documentation, but hadn't been fully appreciated, or we were not able to see evidence of it being thought through and evaluated in the course of the process. Misinterpretation of diagnostic studies. We know from our data set that this is far more in the radiology and imaging area, but certainly pathology contributes to this, as does some of the lab testing. And the issue around obtaining a timely and appropriate consult. These are really the key drivers. 85% of these cases, albeit again, biased by the lens of medical malpractice to begin with, but a plethora of 20/20 hindsight insight to the vulnerabilities that we hope we can learn from and bring to bear on the conversations so that we can think about systems that would support better cognitive thinking in the future. Other issues, 35% of these cases were impacted by communication, 22% by clinical systems. It's important to understand how information passes through our systems, the systems that process test results, and those human failures between providers who aren't communicating adequate information when asking for a consult or reporting on a test finding, and of course communicating those results, as David said right up front. Part of the diagnosis, part of the accuracy of a diagnosis is not only getting it right, but communicating it to the patient. So we're able to see that in many cases here, we had it right, but it was not communicated to the patient. Next slide, please. This is a quick look at something we call the process of care. This is available in a document that you can find on the CRICO website that just takes all those individual vulnerabilities and rolls them up into what we call the process of care to allow you to begin thinking about where in the course of the care delivery process are the most significant vulnerabilities, and how can we begin to have conversations between those of us that have the insights and the frontline providers on how to improve the development or the process of the history and physical. How do we assess? How do we process information and order the right tests? The phase of actually getting the test done and communicating the results. So some really interesting opportunities here to just look at the process of care in relation to these failures. Next slide, please. The most important question, though, that we want to ask for today's conversation is, so what do we do next? And really, the data gives us a very strong indication of where we can start. If we look at the issues that rose to the top, those that are most vulnerable to being costly and catastrophic, and the places that they're having and the vulnerabilities within there, we could start by looking at our adult clinics and tackle those top 5 cancer issues. We can look in our pediatric clinics and arena, tackling the infection areas, and certainly in our ED and inpatient, again, attentiveness to the narrower focus in a vast array of issues that feel overwhelming, narrowing in on those vascular events and infections that are most prevalent in the cases we see that are occurring in ED and inpatient. So we have a really strong lens on what's happening, where it's happening, some strong indications on why it's happening, but then we really want to go a step deeper and really grasp a greater understanding of the what, and more importantly, tie that to the what next. And I think, David, at this point, you're going to share some more insight with us, and then together we're all going to tie that to what we could all do in our next steps to begin addressing the issue of diagnostic vulnerability and moving toward diagnostic excellence. David?
That's super. Thanks, Dana. If I could have the next slide. So we've already heard that diagnostic errors are essentially the bottom of the iceberg of patient safety and quality. They're the most common, most catastrophic, and most costly of medical errors, with a huge toll, both the level of the individual patient and society. Next slide. So the question is, why are there so many diagnostic errors? How could this be happening with such an incredible frequency? And the truth is that medicine's hard. It's difficult, and in some cases you might make the counter argument that says it's a miracle we ever get the diagnosis right. On the other hand, we really shouldn't allow the complexity of the problem to get in the way of the principal question, which is, could we be doing better than we're doing today? And I believe that the answer to that question is an unequivocal yes. Next slide, please. When we think about where diagnostic errors happen and what their underlying root causes are, there's often a framing around this issue of systems errors versus cognitive errors, with systems errors reflecting issues in care coordination, availability of experts, fatigue, distraction, etc., and cognitive errors being clinical reasoning, problem formulation, data gathering skills, etc. This distinction is important in some sense because it helps us get at this question of what are we going to need to fix in order to solve the problem. Next slide. As Dana just showed you in the recent study that we did collaboratively together, the majority of identified error causes or opportunities, causal factors that contributed to these errors really happened in the clinical reasoning phase, the clinical judgment phase. And we've seen the same thing in prior studies that were not malpractice based. For example, Gordy Schiff's excellent study from 2009, a figure of which is shown here now for you, that shows that when they analyzed over 500 physician-reported clinical diagnostic errors, that they found there were numerous missed opportunities that principally happened in the bedside process of diagnostic reasoning. The next slide. So somehow, what we're really trying to accomplish is to take an underlying situation where we have cognitive and system failures that lead to wrong or delayed diagnosis, result in wrong or delayed treatment, and then ultimately result in preventable patient harms. And next slide, convert this into a scenario where instead we're working in a supportive system and culture to achieve correct timely diagnosis, correct timely treatment, and improved patient outcomes. This is a fairly straightforward construct for what we're doing, but when we get into the details, it's obviously a little more complex than that. Next slide. This is a diagram from the systems engineering and patient safety framework put forth by Pascal Carrion's group at the University of Wisconsin, that really identifies the complex interactions between the individuals within a work system who have to go through a series of processes that ultimately hopefully lead to outcomes, and there are feedback loops at every level. And you can see already just by envisioning this kind of a construct how hard it may be to move just one small piece of this and expect to have a substantial change. Next slide. One of the things that we've emphasized here at the Armstrong Institute Center for Diagnostic Excellence at Johns Hopkins is a focus on sort of wraparound solutions that tackle problems from multiple perspectives to get at these different problems in the way the system functions. We've called these the 4 T's to transform diagnosis, and I put these here in front of you today just to give you a taste for the kinds of things that we're working on as a whole and as a community to try to tackle this problem. On the teamwork side, that includes engaging patients, enlisting nurses and allied health professionals, and breaking down sociocultural barriers from a training perspective, working on not just raising awareness, but also leveraging simulations and trying to get at performance in practice as we think about training the next generation of physicians or maintaining the expertise of our physician workforce that we have. On the technology side, discovering new tests, adopting telemedicine and applying decision support, and ultimately giving the system the ability to tune itself through feedback, whether it's through reporting, incident reporting and review of cases, providing feedback to individual providers on their performance in diagnosis, or developing dashboards to identify our overall performance as institutions. The next slide. I think one final point before I hand it off to Paul to talk a little bit about the national lens that's been applied to this problem through the Society to Improve Diagnosis in Medicine and its activities is really around this issue of diagnostic value. It has sometimes been said that people are concerned if we focus on too much on diagnosis that we may end up breaking the piggy bank, that we'll just have people ordering lots of diagnostic tests. And I want to just make a clear argument here that explains why I don't believe that that's the case. In the value equation, where the cost is in the numerator and the quality is in the numerator and cost is in the denominator, you can imagine multiple ways that you can improve value in healthcare. I think most people are generally thinking about the waste reduction version, where quality is held constant, costs are reduced, and value goes up. But really what we're after in diagnosis is the value added scenario, where diagnostic quality goes up and costs go down and value goes up tremendously. Next slide. And here's why that's a realistic possibility for improving diagnosis. So the critical thing about improving diagnosis is that when you improve diagnosis, you are improving on both false negatives and false positives. So in this 2x2 grid, it just shows the standard outcomes of any diagnostic process. Think of this as sort of an encounter level: true positives, true negatives, false positive, false negatives. What we're trying to avoid on the top row is having dangerous things be called benign, the so-called false negatives. We're trying to convert them into true positives, dangerous things called dangerous. On the bottom row, what we're looking for is avoiding unnecessary or inappropriate test overuse, where we're calling benign things dangerous and inappropriately working patients up. And if we convert those to benign called benign, we will ultimately save money. Because on the top row, we're saving lives, the bottom row, we're saving money. If we successfully accomplish the goal of improving diagnosis, that is improving both the accuracy of what we do on both the false positive and the false negative front, we will in fact achieve this value-added solution. So with that, I will close and hand it off to Paul for a discussion of what's happening at a national level.
Thanks, David. And I'm sure we all wish we could spend more time. It's a very rich framework that you have set out there, and the important contributors that Dana laid out earlier. I'm going to sit on this slide for just about 10 or 15 seconds while I talk about what we're going to do next. So at this point in time, hopefully you're saying, okay, I'm convinced. There's a problem. It's a big problem. It costs, it hurts, and we need to do something about it. So what's next? What do we do about it? And the question is an important one. And the answer is not the easiest one that we want to hear, is that there aren't silver bullets. We do not today have in our toolkit the three things that are going to dramatically change the outcomes for patients relative to diagnosis. We know that much already. And the amount of evidence we do have for the interventions that people have been trying is relatively scant. There's some very suggestive data. We've seen lots of things that work, but it's not robust enough yet to say in all settings, in all uses, this will work to dramatically solve your problem. So we do need to do more work. And that's where you all come in. So let's change slides, please. Go to the next slide. And we'll start with this. HRET, under a contract from CMS through the HIN process, contracted with CIDM to try to put a collection together of case studies, of how to think about measures, about interventions that have been tried. Again, you're not going to find this is the answer to all of your needs, but you're going to find a very welcome set of ideas that you can consider for your own situation. We're going to talk more in the next 5 minutes about what some of those ideas are. This reference is available on our website. It's available on HRET's website. Next slide, please. And one of the things you'll find, and it's very useful, is another framework, a framework for driving improvement activities. And it'll outline the 5 key or primary drivers that we see as being critical to success, whatever choices you make about the tactics you're going to pursue. And that secondary set of drivers that you can use to plan and hopefully in a very productive way prioritize your approaches, because you know that it's tied to the drivers. Next slide, please. Within the change package, there is a top 10 checklist. Time will not allow me to read through all of these, but as you've heard already from Adam, these slides will be available to you, and you can also go and get that downloadable change package. But there are 10 top ideas that will give you some idea of where to start and things you should really look at. Next slide, please. And this is just the balance of the 10, the 6 through 10, but you'll see things in it. I'll just call out the last one as an example. We all use fishbone diagrams for root cause analysis, what some people call Ishikawa diagrams. But the standard one most people use does not really suit itself well for the issue of diagnostic error, because diagnostic error, as we learned from Dana, involves both system and cognitive, that the average number of contributing factors to a single diagnostic error is more than 3 contributing factors. And the cognitive at 85%, as well as the system broken out into other subfractions, it really forces us to think about that in our root cause analysis. And so there have been and there are published root cause analysis that have been ideally set up for the diagnostic error analysis. Next slide, please. It's important to, on this journey, to learn from others. We do not want to reinvent the wheel. There's way too much at stake. And from our coalition, which I'll talk about in a little while, from the QI collaborative we ran last year, from our growing networks of organizations that are part of the CIDM community, you'll find that there are a number of great interventions being done. These 4 organizations are just 4 of many who are actively trying to pursue this problem. I'll give a little shout out to Intermountain Healthcare. It's probably one of the very few organizations in the country where the board of directors has even said this is a priority for us and we will have a goal. We need to see more of that, but it's a great step. Next slide, please. I want to take you down into one little case study. Kaiser has their SureNet program, and they actually have many different algorithms, but this is a really relatively simple thing that organizations can do without major change. It's just querying the clinical data warehouse. Most of you will have clinical data warehouses. You may not have the simplicity of Kaiser's situation where all patients are captive to the system. You may not have all of that, but they can go in and you can modify your own or using ACOs or other HIEs or other forms, try to collect that relatively captive population. They go in and just do queries and they look for examples of follow-ups that should occur within a certain time period but haven't, as the clinical data warehouse demonstrates. So in this case, a creatinine test that wasn't repeated within 90 days, it turned out at the end of the process, after bringing patients back in for the additional testing that hadn't occurred, they had a very high pickup of chronic kidney disease diagnoses that were a new problem on the problem list that had not been diagnosed prior to that. Next slide, please. Another example, and you can go to PCPI's website, they have created a toolkit for closing the loop on referrals. By looking back in the malpractice data, we can see that one of the significant contributors to malpractice payouts is breakdowns in the referral process, either the communication between the primary care provider and the specialist, with the patient, with the pathologist or radiologist involved in that whole referral process. And so fixing that referral loop is, again, one thing that you don't need major changes in technology. You don't need to dramatically change your workflows or anything, but you can have an important impact just by trying to address this. Next slide, please. So I'm very pleased to announce that thanks to a grant from the Gordon and Betty Moore Foundation, CIDM is going to be in a position to be awarding grants to health systems in the very near future. These grants will have a $50,000 cap, each one, for a 1 year worth of discovery and trying to improve things. We want to spur activity. We will be giving out approximately 20 grants per year for the next 3 years, so several $1 million being put into the field. This grant is very new, so we have not even developed the RFP or anything, but if you want to be notified, the first RFP will open in January. Please go to our website and click on the sign up for updates, and you will definitely be notified when that RFP is available. Next slide, please. Let me just finish with 3 or 4 minutes on CIDM itself. You've already heard what our vision is and our mission. Next slide. But you didn't hear a lot about our activities. We are very involved in a number of different ways. One, you've heard about the NAM report, which CITM petitioned for and helped fundraise for, so we were definitely a catalyst to that. We have a coalition I'll talk just a minute about a little bit more, but we have over 50 organizations that have joined this coalition, and we have launched a national campaign that's called ACT for Better Diagnosis, where ACT is an acronym for Accurate, Communicated, and Timely. We hold an annual conference that's very cross-cutting. People who attend say it's unlike any of their specialty society conferences, because you're dealing with patients and nurses and risk managers and physicians and clinician educators and researchers and the list and industry. The list goes on and on. So it's very unique, and people tell us it's very stimulating them. We've already talked about the HRET report, and we are also leading efforts in Congress and in agencies like ARC to raise the attention to this problem, and we are seeing dramatic impact and results. Next slide, please. We have a number of resources at our website, our PubMed peer-reviewed journal, Diagnosis, and if you're a donor to our 501c3 charity, you'll actually have free access to the articles in Diagnosis. We put out a newsletter to anyone who's registered at our website called Improve DX, and have a patient-oriented one called DXIQ. The website has a tremendous amount of information available to you for your use that you don't even have to be registered to access, but we hope you will register. And then we're active on social media. Next slide, please. I mentioned our coalition before. Your system should belong to this coalition. It's broad. We have a broad constituency of very major players down to the health system level. These are all organizations, not people, not individuals. And more information can be found at our website. You can contact me. I'll be glad to also answer any questions. Next slide, please. The coalition is based on three main collective actions, and every organizational member identifies an individual action. So one is collective action was to build awareness and engagement, as we already talked about the ACT campaign that launched last September. Two, we've been working very actively to secure funding. There is less funding for diagnostic research out of federal agencies than there is for smallpox, which has been eradicated. This, for the most common, most catastrophic, and most costly of all medical errors, doesn't make sense. So we as a coalition have been working on that, and we as a coalition are working to identify and disseminate effective interventions. So that's an important part to fill that toolkit so that you know what to do. Next slide, please. So let me just close by saying, please get involved. If you just want to stay up to date on what's going on more broadly, visit our website, register there to receive our infrequent but informational updates. If you think your organization should be in the coalition, you can get more information here and email this address, and we'll make sure someone gets back to you to answer your questions. We think this will be important to have hundreds of health systems in the coalition. And finally, you should consider coming to our conference, which will be in DC this year in November. You can get more information, see the speakers and the entire program, including pre-conference workshops and other things at our website, and we hope to see you there. So with that, I'll finish it up and turn it back to Adam to handle the question and answer period. Thank you.
Well, thank you so much, Paul. Thank you for such a phenomenal presentation. We have some great questions coming in from the audience. Audience, if you have questions, please continue to send them in, and let's see what questions we have. So our first question from the audience is for David. David, the question from the audience comes is, do all complaints need a diagnosis? Do all complaints require a diagnosis?
Well, thanks for that question. Certainly, not every chief symptom in medical care. I assume that's what people mean by complaints. Symptoms in medical care necessarily are going to be diagnosable. There are certainly many patients who have what are sometimes now called medically unexplained symptoms. And there are many instances where an encounter shouldn't necessarily end with certainty about a diagnosis, but instead should end with some level of uncertainty about the diagnosis. And sometimes watchful waiting is appropriate. I think the critical thing that especially sort of comes out in the collaborative work that Dana and I did through this CRICO Johns Hopkins collaboration is that the usual suspects are responsible for the majority of harms from diagnostic error. It's not the rarest of rare conditions. So what we ought to be able to do is make sure that we're not missing these diagnostic emergencies, things that are threatening, time-dependent, treatable, and tricky. Those are the kinds of things that we should be focusing on not missing in patients who have symptoms. If people walk out without a firm diagnosis, but it's something that can wait, then that's a very reasonable expectation for patients and for physicians to have.
Great. And another question for Paul. Paul, how can independent health plans help in this process?
Well, independent health plans can certainly ensure that actions are taking place within the systems to encourage completion of care, the follow-throughs, follow-up, both in their payment policies, but also in terms of the expectations. So many health systems have incident reporting systems that don't even aggregate or even classify errors as diagnostic errors. They go into some other category. Health plans need to be ensuring that the patients for which they are overseeing are collecting the data in a meaningful way, and so that certainly prioritization can occur. Of course, anything having to do with reimbursing the right kind of emphasis on diagnosis and not on treatments as a priority. The treatments obviously have to come, but if we shortchange the diagnostic process, then we will end up paying for it in inappropriate treatments later. So those are just a few initial ideas.
Fantastic. And audience, if you have questions, continue to send them in. We'll take your questions, as many as we can, up to the end of the hour. The next question is for our resident RN, Dana. Dana, the question is, in what ways can nurses intervene with this problem? Do you have any suggestions or insights on that?
Thank you for that excellent question. I love the thought process that nurses are, in fact, part of the diagnostic team, and I think it's really one of the key focuses of really wanting to broaden the conceptual or visual understanding of who's responsible for diagnosis. And we've certainly moved far away from the image of the single clinician within their own space, trying to work through all the problems and issues that are presented by the patient and coming up with the right direction. I think for nurses, we are excellent at frontline assessment, whether that be triage on the phone for a patient calling for an appointment, triage in an ED space, or direct bedside service to a patient that's in the hospital or in the emergency room. I think our assessment skills and our ability to communicate finite changes in a patient's condition, our ability to listen and hear, and in our inpatient arena, spend more direct bedside time with patients than our providers often have an opportunity to. We want to be sure that we see ourselves as a conduit, the eyes and ears of the physician, and the voice of the patient, and bringing that together, and really ensuring that we're escalating our observations and certainly our visions, our diagnostic implications and images of what's going on with the patient. We should not be afraid to have a voice and to be recognized as a partner in the process.
Fantastic. Fantastic. Next question is for David. David, are there patients who have a higher risk of misdiagnosis, and who would they be?
Yes, so there's some evidence on this question. Obviously, the the single biggest risk factor that people are maybe not familiar with is the degree of atypicalness of a given clinical case. So it turns out, for instance, patients who have stroke, for example, something that we've studied extensively, we generally don't miss patients who have stroke when they present with paralysis on one side of the body and the inability to speak. We miss strokes when they present looking like other things, such as with dizziness or vertigo or isolated headaches. And so the degree of atypicalness of the initial case presentation relative to sort of the classic paradigm for any given symptom is probably the single biggest factor. So clinical factors play a role, but demographic factors, which I think is probably what the question was getting at, are also an important piece of the puzzle. And those happen probably for a couple of different reasons. We've shown, for instance, that using very large data set analyses that diagnostic errors are 20 to 30% more frequent in women and in minorities when it comes to stroke misdiagnosis. And that increase is similar to the kinds of increases for women and minorities for other medical errors in patient safety. So it's not all that surprising. It's unfortunate, and we'd obviously like to close that disparity gap. The extent to which that's based upon biological differences and clinical differences between those individuals and their white male counterparts versus due to some kind of implicit bias related to their race or gender is a matter that hasn't been fully teased out. Finally, I just want to say that one of the things that's very underappreciated in terms of demographic disparities is when illnesses are presenting in an age group that isn't expected, they are often at very high risk for misdiagnosis. So for example, younger patients, 18 to 45, we've shown are 700% more likely, or sevenfold more likely to be misdiagnosed than their elderly counterparts over the age of 75 when it comes to a stroke diagnosis. So, and there again, it's sort of an atypical out of sight, out of mind problem.
Wow, sevenfold. Paul, I'd love to follow up with you on that one. What is SIDM doing about disparities? Can you talk to us about that?
Sure, and not nearly as much as we want to be doing and hope to be doing in the future, but we are doing things on it. So number one, we do have a grant where we're partnering, where we're the primary, but we're partnering with Stanford to study diagnostic errors with disparities. We're looking at visual attributes of age, gender, and race to try to understand better from a patient perspective how these errors have happened and trying to see what we can learn with that. We are certainly, as we build this RFP for the seed grants that I mentioned earlier, one of the priority categories that is under discussion still, I don't want to commit to this just yet, is to address the issue of disparities. And we have submitted some applications, some proposals to try to get at this question in a bigger way. We do think that we know from David and Dana's work about the disease categories. We don't know if we use a different lens, will there be some other cross-cutting solutions? And we think disparities is an important area to still pursue and explore to try to understand what other lenses can be brought to bear.
Fantastic. Moving on to Dana. Dana, how can systems identify at-risk patients and lower the chances of misdiagnosis? Can you give us some best practices?
I think one of the most promising practices from a system support was mentioned earlier in the program and certainly worthy of re-mentioning again, and that's the safety net program that Kaiser's been working on, where they're actually looking to find what we are calling here at the Harvard community, where we're emulating that program, unanswered results that live within the electronic health record or EMR, test findings and symptomatology that's been identified and don't appear to have a connected follow-up call or appointment. Of course, this is best applied in closed systems where the test results and the follow-up care would be within the same system and care processes and electronic health record. I think a lot of the work about closing systems on test result reporting in general, and particularly on consultation, is really critical for us, where we need to rely on our systems to help us understand when we've sent requests for information or sent our patients out into the world, again, particularly in that ambulatory arena, where we are more vulnerable to the elongated time frame around the diagnostic process. We really need stronger systems and checkpoints where we're making sure that tests that have been requested have follow-up results, consultations that patients have been sent for, the information's been received, and more importantly, communicated and acted on. And we're still continuing to explore every day more acute ways in which alerts within our electronic health records might alert us to a volume of blood that has appeared to be asked for at a blood bank that triggers a sense that maybe there's a failure to rescue scenario going on in the post-op arena. So there's a number of ways in which we're asking our electronic systems to support and embrace and provide safety to our cognitive processing. And that we're hoping that those shore up the partnership, if you will, between thinking and acting and the systems that support the decisions we make.
Wonderful. Well, we've got time for just one more question, and I'd love to take it to David. David, you mentioned 3 major disease categories earlier that really are significant to diagnosis and to the study that you did with Dana's team. Can you talk about those categories a little bit more and why they're so significant to this conversation?
Sure. We've called these the big 3 categories: vascular events, infections, and cancers. And what we found in the study that we did with Dana and Kryko was that about 75% of all the serious harms from diagnostic errors were accounted for by diseases in those buckets. And sort of drilling down one layer even further, if we looked at the top 5 in each of those categories and took those 15 together, that together those accounted for about 50% of the diagnostic errors. And what's so critically important about that finding is that we know that at some level diagnostic errors is a problem that affects every area of medicine, every disease, and every problem. And it can feel overwhelming to tackle such a vast, difficult issue. So what we've found now in looking at the cases that have the most serious outcomes that matter most to patients, that is death and permanent disability, that perhaps if we focused our energy on some high yield areas, like those 15 diseases, we might be able to take a huge chunk out of that harm just by solving a relatively finite number of problems. So I think that's really the main takeaway message for me anyway from our big 3 study, is that this is an opportunity for us to know where to start on this journey towards improving diagnosis.
Fantastic. Well, thank you, David, for that fantastic answer. And that takes us to the top of the hour, and it's time to conclude today's presentation. A special thanks to our audience for the great questions, and thank you to our speakers, Paul Epner, Dr. David Newman Toker, and Dana Siegel for your thoughtful contributions. To our audience, we value your time and feedback. Please take a moment to fill out our brief post-webinar survey so that we can provide the best content and resources for you. We'd like to thank the sponsor of today's webinar, the Society to Improve Diagnosis in Medicine. For more information about SIDM, please visit improveddiagnosis.org. This webinar will be available on demand, and a link to a recording along with a copy of the slides will be emailed to you within the next 48 hours. This concludes today's presentation. Have a great day.